Okay, so many times you have to explant a lens. And the question is, how do you explant it safely? And what is the right time to explant an IOL or exchange an IOL? So I had different conditions. Of course, we know it from theory when to do it, but I could show you practically in some situations of how to go about it. So here's a patient who came for a second follow-up at 15 days, and we realized that he has a toric lens, you can see that, and we realized that instead of the toricity getting reduced, it doubled up. That means it was 2-cylinder, it became 4-cylinder. That means the lens was placed at an axis 90 degree to its actual required position. So it was 2 weeks. The lens does not get trapped or encapsulated, or there's a shrink wrap effect. So you can just open up the bag, put viscoelastic, and do what is called a visco dissection. The visco wave passes under the IOL, you do a counter pressure, the lens is free, you can rotate it in position, and the job is done. So, it is best that when the patient comes at 2 weeks, and you see that this lens has to be rotated, dialed, explanted, or anything, that's the best time. Now, we'll show you another situation, what happens at 3 weeks. So here was this patient, and the IOL had to be taken out for some reason, and we again tried to first separate the anterior capsule and then do a visco dissection. You can see that little fiber going under the IOL. So that's an idea of how the visco is moving under the IOL. Counter pressure, the visco wave is complete. And then we try to pull out the lens from the capsular bag and see what happens. The optics are clear, but the haptics are entangled in the fornix of the bag in a fibrotic hold. Now see the other side also. A routine IQ lens, a very friendly lens in the eye. And see this hold on the haptics in the capsular bag by some fibrotic bands which are holding the haptics in the bag. So, inference at 3 weeks, the fibrosis kind of sets in. It becomes a little difficult to take out the lens out of the bag at 3 weeks, but 3 weeks, 4 weeks, it is doable with a little effort. Then let's have another situation. An opacified lens 4 years after surgery came for a lens exchange. 4 years after surgery. You would have had all that shrink wrap effect, fibrosis, adherent of the capsule to the lens, strongly adherent haptics to the fornix of the bag. How do you handle it? So my first job was to find one point of entry where I could enter my probe under the anterior capsule, between the anterior capsule and the IOL. I'm just searching for that one point where I can enter in, because the whole thing is stuck to the IOL. I got one point of entry, and then I can move it around and separate the anterior capsule from the optics of the IOL. So this is separation of 1/2. Now I'm trying for the other side. Again, I'm not gaining an entry here. So I go through the previous part of the entry and separate the anterior capsule. Now the anterior capsule is separated. Now the big challenge. See the kind of hold of the optics in the capsular fornix, highly fibrosed. I'm trying counter pressure to pull this out because it would have pulled the bag, the zonules, and there would have been a bag descents and everything, but still with counter pressure trying to keep the capsule in position, I am able to bring out the haptic from out of the bag. See, I'm again giving counter pressure to the phonics in the bag so that I don't want the whole bag to come out with the haptics. Any times you can almost see the edge of the capsular bag and the zonules, but somehow I managed to get it out. Now, the carry home point here is, what if the adhesion was so tight that I could not separate it from the capsular bag? What would I have done? So what I would have done is, I would have chopped off the haptics. Let the haptics be there, bring out the IOL only, and then put another IOL in the bag. So the take-home messages here would be, at 2 weeks, when the patient is coming for a follow-up, if there is a problem, do it then. You have 2 weeks, 3 weeks to take your decision. 3 weeks, the fibrosis starts setting in. And 3 months onwards, you can never be sure how much of fibrosis has set in. Then it is your stake, it is your chance. You could be successful, you could get caught up in a difficult situation, but even difficult situations are manageable. Thank you so much.
What I'm saying is that this is good to show that at early post-op, of course, it is easier to take it out. I think it would also depend on how the original surgery has gone. Like the last case didn't look, a very simple case, or didn't look as though everything would have gone well, because the rhexis was not circular. So it will also depend on the architecture of your rhexis at the primary surgery and how the surgery has, gone. Even if the case is old, but if your capsular rhexis is circular and it's actually overlapping the edges of the optic, then it's easy to do it, rather than, if it is extending to one side, and then things can get difficult.
True.
Just one more point, sir. Once you detect any kind of fibrosis, as you said, after 3 weeks, would it be prudent to just cut at the optic-haptic junction and leave the haptics be and take out the optic and put another IOL?
See, you could do it, but if you know your timing well, and you know at this time I can do it, and when you pull out the haptics, you don't just pull it out. You have to pull a very slow and a steady pull. Keep watching for the edge of the capsule. If it is pulling the edge of the capsule and the zonules, then you try to give a counter pressure with an instrument, but not that strong enough because the counter pressure punctures the capsule and goes out. So it's all a balance. And if it is not working, then you chop it off. Thank you.
Taking out the entire lens through the bag definitely, some journalists would have, been stretched.
So we put a CTR.
You have a, option. We should put a CTR in those cases also. Then do our procedures.
True. I had another video, but time was 7 minutes, so I had to cut that.
Thank you for making up the time. Thank you.